Hey, She Slayers, and welcome to another episode of She Slays the Day podcast. I am your host, Dr. Lauren Brunslick. Okay, so I'm coming off of a crazy April. A lot of you guys, so I had the closing of my 10-week course, Multi Passionate Chiropreneur. We had that live event. That was awesome. Now, last year around this time, this is when I completely crashed because I went from creating the course, selling the course, doing the actually holding the course for 20 some people, and then the live event. And then I took like the next 3 months off to recover. Well, this year I knew that really wasn't an option because I had committed to 2 speaking gigs the following weeks. And my associate was going to be in the Dominican getting married. And so I was solo docking at our clinic in between the 2 speaking gigs. So, anyways, real long story short, it'll be a whole episode someday. I didn't end up going to one of those speaking gigs. Sorry, Elise. I was supposed to go to her Cairo Intensive Retention Summit, and my physical body had other plans. Mentally, I was so there. My speech was so good. But it just didn't happen. So, like I said, long story, we'll get to that one. I now have a heart monitor for said medical reason. But I did get my ass on a plane to Nashville with my 12-year-old. All right, so I learned some critical things for those that are like, "Hey, yeah, I really love this idea of taking my kid on like with me for like work to show them here are my lessons that I learned." This could in itself be an episode. But one, if you have a large social media following and you are taking a preteen, middle schooler, do not announce to them that you are bringing your daughter for her birthday. And that this is your first mother daughter. Don't, because what your tween wants to do is absolutely soak into the wall like a wallflower. And I did not allow that for Charlie by telling everybody, like, oh, Charlie's going to be there. And so that poor girl, that poor introvert, she is not like me at all. But even me at 12 was like, oh, I don't want to talk to you. Had so many people coming up to her. Let's see. Another thing is this is a really great time to, if you have your children as employees and are putting money into a Roth for them, this is a great excuse to do so. So Charlie got paid $2,000 to be my AV girl. So she was in the room taking pictures and video of me. And then I had my very tax savvy friends take pictures of Charlie doing that. So she was like super excited because I was like, "You're going to get paid for this." And she's like, "I am." And I'm like, "Yeah, you're getting paid 2 grand." And she's like, "What?" I'm like, "You won't be able to touch it until you're 65. But do you know how much money that will be?" I think Kirby calculated it's like $250,000 or something like that. So a really nice way for those that are like, yeah, I have my kids, like I'm putting money in their Roth and this and that, but like what are good excuses? Yeah, AV. Third, what was my third lesson? Oh, all right. Well, this may have been to my daughter's personality specifically, but I don't think I realized how much of exploring a city is kind of just like walking, looking at stuff, drinking coffee, drinking cocktails, more coffee, more cocktails. Now we're shopping because we had cocktails and like, oh, that music sounds nice. Should we bump in there for another cocktail? I didn't realize. I should have realized. So I had plans for us, but it didn't like fill the time. And then she also did not want to wait in line. So like there was like the best Nashville hot chicken, but there was a line, but you could drink a beer while standing in line. And it wasn't that bad. I would guess it was gonna be like a 45-minute line. And she's like, "I don't really like chicken." And I'm like, "Cool, yep." And then she's like, "I also don't really like live music." And I'm like, "Awesome. Yes, this is totally fine." I am and then, like, Nashville doesn't take reservations, which can just be really stressful when it's just you and your kid, and you're like, "Oh, this restaurant looks good," and you go, and they're like, "We have an hour and a half wait," and you're like, "Well, we're not gonna sit at the bar and wait, so I guess we'll keep going." So just things to learn, keeping in mind. I have a new review. This is on Apple Podcasts and it's specific and honest. It's 5 stars because I don't read the 3-star ones. Although, again, I don't wanna call this out into the universe, but you guys know if I just got a scathing one-star review, I would read the shit out of that on the podcast. Like, I wouldn't be mean. I would just probably be funny because, like, nobody leaves a one-star don't leave a one-star review just to, like, get a rise out of me. I will be hurt. Anyways, this says, "How nice it is to have a podcast where you can truly relate to the host. Love the raw honesty and the focus on chiropractic." From Dr. Jess D.C. Thank you, Jess. So I have asked for reviews many times, but I am learning, I am growing, and I have a favor to ask you guys, and it's not to leave a review. You thought I was gonna ask for a review, and you're like, "Nope, next." I So most of you listen on Apple and Spotify. If you could do me just a little favor, when you are on, like, the main home screen for She Slays the Day podcast, there is going to be a button on Apple, I'm pretty sure it's, like, the upper right-hand corner. In Spotify, it's kinda, like, right under the picture, and it's gonna say follow or subscribe, one or the other. If you could click that button, that would just, like, really solidify this best friend situation, because apparently that does help, even, dare I say, more so than reviews. So if you have been working on your love letter to me and you just haven't really gotten it and you haven't gotten a chance to write a review, hey, while you're perfecting it, just go click follow or subscribe, and that would be awesome. I also learned that we ranked last week number 207 in New Zealand under business. So, hey, New Zealand, how you doing? I think I need to come visit y'all. That sounds great. How about if I get to the top 50 in New Zealand? I'll come do a talk over there. All right. So today we're continuing the birth thing. How are you guys feeling about this? Like, this is not going to turn into a birth podcast. I can just tell you that right now. I have too many diverse interests to only talk about one subject, which is actually kind of part of the problem. But we have Rebecca Dekker today, and she is a nurse with her PhD, and she's the founder and CEO of Evidence Based Birth and the author of Babies Are Not Pizzas. They're born, not delivered. Previously, Dr. Dekker was an assistant professor of nursing at the University of Kentucky. In 2016, she shifted gears to focus full time on the mission of evidence based birth. Dr. Dekker and Team EBB are committed to creating a world in which all families have access to safe, respectful, evidence based, and empowering care during pregnancy, birth, and postpartum. EBB does this by boldly making the research evidence on childbirth freely and publicly accessible. Dr. Dekker is also host of the Evidence Based Birth podcast with more than 5.5 million downloads. Whoa, girl. Shit. Get it. That's a lot of downloads. So I'm going to have some links for you below that she references in this. Really, so you know me, I'm not like super into research, but I was like, yeah, let's talk about it. We kind of just started doing not rapid fire, but I was just like, oh, okay. Talk to me about this birth myth. Is it true? Is it founded? Like, is the 24-hour water break? Is that true? Is that founded? Like some of this stuff. And she's got some great resources for your patients. So for especially if you're more of like a high volume doc like me and you're trying to figure out how you can really help women do like create the birth they want and inform them, and maybe you don't have the time to sit knee to knee and spend 10 minutes going over some of these things. These are just great things that you can have printed out in your clinic. Maybe make a little like folder, put some like fun stuff in there, and there you go. That's a great gift for any new patient. You're welcome. Let's pray and get down to business. Dear God, I have no idea what I was going to say to you. Usually I am prepared to talk, and today I'm just not prepared. So we'll just take a breath and we'll just hang out together, and we'll just allow everyone listening in this moment to just relax their jaw, ground themselves, whether they're standing or sitting, and just realize that you are here right now in this moment, and focus on mindfulness. Pay attention to something you're hearing besides my voice, something you're feeling, maybe something you're smelling, and just be ever present in this moment. You are living life right now, right now. And maybe you don't have time to meditate, but just being conscious of like slowing down your day with me for a second before you jump back in. In your name we pray. Amen. Okay, here is my conversation with Rebecca Dekker. Enjoy. Welcome to the show, Rebecca. So, I would love to understand a little more of your background. So, you have a doctorate in nursing and philosophy and all this stuff, and you really got into the world of evidence based. So, you must love like geeking out on stuff. That's for sure. That's what I got
Yeah.
from like reading your bio. Is
I'm
like,
a researcher at heart, that's for sure. I love going down rabbit holes and learning as much as I can about different subjects. And so when it came to birth, it was after I had my first child that I really started about a year later, because I think a lot of people start a year after they give birth processing
right,
really
they're
what
busy the
happened.
first. Yeah.
You're very busy the first year. And I made a list of everything that had happened to me in my birth. And I was like, okay, I'm going to research all of these because I had just finished my doctorate at the time. I had access to all the research, I could understand the research. And what happened is, as I went through the bullet point list of everything that happened to me, I began to find all this research and realize that almost everything that had happened to me was not based on the research, but it was based instead on longstanding kind of cultural traditions of that medical unit.
Okay.
And that really shocked me because as a nursing professor, teacher, researcher, everything we talked about was like, what does the evidence say? What's evidence based nursing practice? So I was really taken aback that I was not given evidence based care at an academic medical center. And that started me on a whole journey of like learning the evidence on all the options so that I could make the best decisions for my next pregnancy. And then after I gave birth that time, I felt so empowered by the model of care that I received that I realized I would love for other people to be able to access that kind of care, whether it's at a hospital or a home or a birthing center, just to be able to have all that information and to make choices that are the best for you, and then to feel completely supported in your choices.
Yeah, that's
So
kind
that's
of
when
the clutch point.
yeah, so I kind of just took everything I've been collecting and started posting it on a blog because this was about 12 years ago. And that's what people did. They started blogs, they didn't start podcasts. And I thought maybe 10 or 11 people might find it, but it took on a life of its own. And people all around the world were so hungry for this information. Because I don't know about you, but it seems to me that most people are not given a lot of education about birth in high school leading up to when you have kids. And then when you in your prenatal appointments, you don't really learn that much. It's almost like all this information is locked away in the medical journals.
Mhm.
And there was a hunger for information. So
So
that's kind of how
was
it
were
started.
both of your births in hospitals?
So my first one was in a hospital. I was a student at the time. I really wanted the nurses to
A
like
nursing
me.
student,
Yeah,
right?
well, no,
Okay.
I was a PhD student
Okay.
in nursing. I was already a nurse.
Okay.
But being a nurse and having practiced as a nurse, I know what it felt like to hear the other nurses like gossiping about a patient at the
Uh-huh.
nurse's station, and I did not want to be that patient,
Right.
you know? Because I know those patients get worse care. Like to me it was important to be likable.
Mhm.
And as women we're often people pleasers, and so I was more concerned about pleasing the healthcare staff than advocating for myself.
So when you were reflecting on that first birth, what can you give some examples of some things that happened that you were like, "Well, that's not necessarily what the evidence-based research would have supported?"
Oh yeah. Some of the first things that stuck out to me when I arrived, they told me that I wasn't allowed to eat anymore or
Right. Oh,
drink
yeah.
anything.
Standard. Standard.
Yeah, I was not allowed to even take a sip of water to take my allergy medication. The other thing they told me is that because my water had broken, they said I can't stand up or the cord will prolapse. So they told me I was not allowed out of bed. So I wasn't even allowed to walk to the bathroom to use the bathroom. Instead, they made me use a bedpan, which then I had trouble peeing in a bedpan. It's really hard to pee when you're laying on your back. And then I still couldn't go. So they had to catheterize me. They also strapped the fetal monitors on me. And I ended up laying on my back for 24 hours straight, which is a chiropractor,
Yeah.
first of all, you're not supposed to lay on your back when you're that pregnant, but also that does not help the baby move down and
Right?
out, right? So what ended up happening is, I had a 24-hour labor, which is pretty typical for a first-time mom. But by the end, I was completely exhausted. I hadn't had anything to eat or drink in 24 hours. They'd been giving me IV fluids. I'd been laying on my back for 24 hours. And I'd had an epidural for like the last 12 hours. And so by the time it came for me to push, I knew I needed to push. And I pushed the call light and they said it was 7 p.m. I don't know if any of you know what 7 p.m. is in the hospital, but that's shift change.
Oh.
Yeah. So they said, we're sorry, you can't push right now. We're in report.
What?
So I pushed the button to give myself more doses of pain medication through the epidural to numb myself because the urge to
Because now
push was
wasn't a good time for you to push
no,
for
I
them.
wasn't allowed to. So I numbed myself. And then when this whole team came in all dressed up in gear at 7:30, I I couldn't push
Right.
because I was completely numb. And also, when I finally began to push, I pushed for like an hour and I wasn't making any progress. Pushed another hour, still no progress. And what ended up finally happening is the doctor realized the baby was posterior. So the baby was not coming out in a way that
Right.
makes it easy. And it's partly because I'd been laying on my
I was gonna
back.
say you were on your back,
I was
yeah.
on my back, and nobody ever suggested that I move to my side or get in a different position. So the doctor did do something called manual rotation, which is evidence-based to lower the risk of C-section, but basically she had to insert her whole hand into me, turn the baby, and then I was able to start pushing, but by then I was really tired. So what ended up happening is I needed a vacuum assisted delivery to birth the baby. Now, this was not a big baby. She weighed 6 pounds, 8 ounces. And I had pushed for 3 hours and she came out healthy, crying, red, but they whisked her away for observation. And so the final thing that I learned that had happened to me that was not evidence based, but I didn't need evidence to tell me this, is that they separated me from her for 3.5 hours.
Oh,
And I kept pushing my call light saying, "Can you please bring my baby to me?" And they
can you
said,
please? She's still trying to
yeah.
be nice.
I
Um,
was
hi, you know that thing that just came out of me? Can I have it back, please? Please, if it's
Yeah,
convenient for
and
you.
I was still, paralyzed from the waist down, so I couldn't get up, to go get my baby or demand my baby. All I could do is press the button. And at one point I remember I pressed the call light and said, "Can I please have my baby? I really need to breastfeed." And they said, "We're so sorry. We just gave her a bath and her hair is all wet. So you can't have her until her hair is dry."
What the
This just shows you how much of a people pleaser I was. I thought I was like, wow, she did have a lot of hair. So that makes sense. She had this big head of like, thick hair. And anyways, they
Sorry, wait,
finally
I have
brought
a
her to
question on
me.
that. So,
Yeah.
do is that like an actual, like, thing that they do at the hospital where it's like, "Oh, was she's gonna catch a cold if she has wet hair," or were they
I
buying
don't know.
time?
I think it was the middle of the night. I think they were short staffed and they just didn't have it would have taken more time to bring her out of the nursery to me and help me breastfeed. I think it was just easier to keep her in the nursery. And and so they were just giving me excuses. But anyways, looking at all the research, none of those things are evidence based. Like evidence does not support withholding food and drink in labor. It definitely shows that it's harmful to lay on your back during labor. And it's extremely harmful to separate a mother from the newborn child without a specific medical reason where you're trying to save
Mhm.
their life, maybe. So, yeah, those are just some of the things that happened to me. There were others, but the one that bothered me the most was the separation. And within a few years, that was no longer standard practice at my hospital. They were emphasizing skin to skin, the golden hour. But what I have learned is that women who have C sections still experience that at most hospitals where they're separated for 1 to 2 hours. So that was the most traumatic part of it all for me.
So, I mean, I think that everybody listening probably knows that, like, initially, like the why would this happen? So a lot of it is set up for doctors' convenience. I think, but I wanna play or ask the question of, like, the devil advocacy question here is, like, do you think that some of this is there because America has such a bad rap sheet when it comes to, like, birthing outcomes and infant mortality and things like that? Like, are some of these things like, we can't give the baby to the mom, we have to keep the baby alive, or, like, beyond, like, well, it's all set up for doctor convenience. What other reasons does a hospital have to go against the information or the research?
Yeah, I think I can't speak for every scenario, but in my scenario, it was not for medical reasons. I can tell you that. My husband did go get a video of my daughter through the nursery window, and she was looking around and like kind of moving her little arms, and nobody was near her. There was not a single staff member. She was like all alone in an isolette, totally healthy. I think in a lot of cases, it comes down to staffing, tradition, convenience, and just a lack of priority of the family unit. So there was not a prioritization in keeping the family together, in centering the mother and baby in that relationship. There was not an emphasis on breastfeeding at the time in that hospital. It's since changed. So their solution is just to give a bottle for everything. And, going back to my own mother, she had twilight sleep with my older siblings, where they actually completely knocked her out, and she was not allowed to see her baby for about 12 hours. And then she was allowed to see them like once or twice a day. And then it's just been over time gradually shifting to keeping the family together, because then we had rooming out versus rooming in, where you didn't sleep, your baby was taken away for the night. And then now it's gradually rooming in, but still, it's never been this one moment where we were like, let's do what's best for moms and babies. Instead, it was just shifts over time. And in some places, things are still really outdated.
Things seem to move really slowly.
Yeah.
Do you think, like, is that specific to this area, or do you think, like, all across healthcare things move really slowly? And why does it move so slowly?
Yeah.
Like, I
So
just think
yeah,
I
research shows it takes about 10 to 15 years, 15 to 20 years for research evidence to be put into regular practice. And one of the reasons I was so shocked by what happened to me is because my previous area of practice was cardiovascular,
okay.
and we were so on top of the latest research with everything related to heart attacks and different congestive heart failure. It was all about what is the latest research, what are the medications and the pros and the cons, and we were so focused on the research that it was surprising to me. And that's one reason when I went to have a baby, I just trusted what they told me.
Mhm.
So I think there are always going to be aspects of care that are outdated in any field because we have individual practitioners and not everybody stays up to date. But there's something about obstetrics that has kept some of these outdated practices in play. And I think that has to do with because we have come so far, we're so far removed from the type of care where we centered the families.
Yeah, so do you think that like, okay, so with cardiovascular,
Yeah.
new stuff is, like, cutting edge, right?
Right.
And so it's like, "Oh, like, this is," and there was never really, I can't imagine, I've never worked in a cardiovascular unit, but I would imagine there was never a rejection of the old school health model of, like, having a healthy BMI and, like, things like that. It wasn't like, "Ew, exercise and healthy diet, like, that's so
It was
old school."
bad. Yeah.
Right, like, there was never a rejection of the old way of thinking about what's heart healthy. Now, when we look at maternal and infant health and obstetrics, the old school stuff is home birthing and doulas and, like, real, like, going out into a field, or, like, so I think, and then when you look at, like, what needs to happen in, and please, like, disagree, or it seems like a lot of the research is kind of pointing to, like you just said, we've gotten so far from where it used to be, should be, where things were, and the idea of returning to that isn't cutting edge. It's not like, "Oh, what about this? What if we let the mom not be attached to any monitors and she just, like, can freely walk and use gravity and squat and, like, the dad catches the baby?" Like a doctor that can seem so primitive. It's not considered it's not thought of as do you think that
Right.
attributes to it at all?
And there's no money attached to
Oh,
that, So, and I don't believe everything is conspiracy theory about money, but there's no financial incentive to simplify birth, even though simplifying it might be, in most cases, what would be helpful. I think in the ideal world, we would have the ability to have the physiological, the primitive, the holistic ways of birthing, and then have medical interventions for the situations where they're needed or wanted. But it's almost like it's backwards from that. It's like we give everybody the medical interventions and then you have to fight to get something that's not an intervention, at least in the United States and Canada. I would say in other parts of the world, that's a different story. In some parts of the world, you can't get the interventions. So we have a very mixed bag around the world.
so Canada has similar, like, birthing situations to us?
They have problems just
Yeah,
like the US does. So they have universal health care. So people aren't worried about getting health coverage or paying for their birth like they do in the US. But they still have shortages of midwives and they still have birthing units where you might feel pressured into doing things a certain way
got it.
and
So
high
then
C-section rates.
So
Mhm.
then because that's what I was thinking is like, how do you remove the capitalism? Would that be the like capitalism from birth? And I thought that the answer was like, oh, universal healthcare, but like apparently not. So then when you're looking at because your goal is to improve global outcomes, correct? So what are some of the countries that are doing this the best that we might look at as more of a capitalistic society still. So like, I don't know, I'm gonna like put my foot in my mouth and call but like, yes, a third world country, like, yeah, they might be nailing this, and this on like the infant mortality, like ratings. But it's like, well, why? Well, because they're not even in a like it is that. So like in some of these countries that have hospital systems that need to pay their bills, that need to staff. Do you know of any that are doing this well?
So there are hospitals in the US that are doing it well.
Okay.
That might be more helpful because when you're
Mhm.
talking about low resource countries, you have a very different set of problems. Like I mentioned earlier, you have total and inaccessibility to basic medical interventions, testing, treatment, and very high maternal mortality rates. United States has the highest maternal mortality rate of the well-resourced nations. There are
Oh,
some places where it's done well. There is, I'm familiar with one small hospital in California where they have a doula program. So everyone who wants a doula can have one without added cost. They provide water birth. The midwives are the main providers on the unit. They have very low C section rates, very high satisfaction, but that's very different. And I think it comes down to the culture of the providers and the practitioners at that hospital.
is that like a luxury hospital? Like, is
No,
that no.
no, no. And in fact, I would say some of the better birthing units I've seen in the United States have been in small rural communities where there's just a few doctors and midwives who've worked there forever and they know their community and they're more open minded because they're not. Sometimes the bigger, fancier hospitals are actually the worst ones to give birth at.
Because there's so much bureaucracy? Like, you're like, is it that we're not giving doctors the ability to be critical thinkers? Like,
Yeah.
there's such
So
like a program of like, when she presents this way, this is what you do.
hmm. So when you think about picking a hospital, if you're deciding to go with a hospital for a hospital birth, like what do you think most people are looking at when they pick a hospital?
Proximity to their house.
Hmm. And what else? If say there
Uh,
were three within a similar distance, which one would you pick? I mean, coming from
um
the perspective of like a mainstream parent.
Right, 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 right. My insurance is gonna cover there.
Yeah. Anything else?
Um, I mean, I can't get over the, like, "Is there a NICU?" But
Yeah.
that would
Okay.
probably
So,
be
what's the level of NICU care? Perhaps some parents might think of that. Often they're thinking they pick the one that has the most billboards, you know, advertising their beautiful birthing units.
Mhm. Yes.
Or maybe the newer facility that has a newer, nicer building. Or maybe it's the popular one that most people in town go to.
Yeah. That makes sense.
Okay. So, do you think that people will look up the statistics for that hospital?
Can you even look up the statistics for a hospital?
Yeah. Mhm.
Where do you do that? Because I remember asking God, my kids are old now. Well, I mean, they're not old, like 9 and 12. And so I did an out of hospital for both, but with my first, I had an appointment with an OB to have a file just in case I needed to be, like, transported. So I'd be like it was basically me showing up being like, "Just so you know, I'm Lauren. I am pregnant. I'm not planning on being here, but if I roll in the middle of the night, you know who I am." And I asked like, "So what is your C-section rate?" And they're like, "Oh, we don't keep those kind of stats here." It's like, I have a feeling that's not true.
Well, that's what I would call a red flag,
Yeah.
right?
Right.
So, if they don't know their statistics or they're not transparent with them, then that's not a good sign. It means they don't care about or they're
Mhm.
hiding something. So, there's a nonprofit called Leapfrog, and they do all kinds of quality rankings on hospitals, and it's totally voluntary, so hospitals don't have to give them their numbers, but
Mhm.
most do because then it kind of looks bad if they don't. So you can go to Leapfrog and Google like Leapfrog hospital compare, and you can actually pick 3 hospitals close to you. Click that you want to compare them, and it will give you their statistics for their cesarean rate for low risk moms and the episiotomy rate and a few other important statistics you might want to know.
Mhm.
So, understanding like what the C-section rate is in your area, and some hospitals, if you say you're in like a town like mine where there's 3 major hospitals in the city, if you don't know the C-section rates, you would have no idea that kind of the one that looks less nice from the outside actually has the best outcomes if you don't look that up. And also understanding who the providers are there and what are their typical practices. And sometimes the best way to learn that is to talk with a doula. I think it's also something chiropractors should be able to look up as well, and
Mhm.
and be able to point their clients to, oh, you're pregnant, like here's how you find the health outcomes from the different hospitals. Here's a list of OBs that our clients have had good experiences with, or midwives. And I think there needs to be a lot more discussion because people just tend to go with either who they had for their GYN care or who they think, their insurance covers, or maybe my friend used them. But the problem is who you choose to be your provider has a really important impact on your birth, which then can go on to impact your health. And so, one of the things I didn't tell you about the story of my first baby's birth is that I actually had a good relationship with my OBGYN, and she practiced something called continuity of care, which means at the time she promised to come to my birth. Now, very few OBs do that these days. If you really want that, it's easier to find with a midwife
Yeah.
clinic, although even they sometimes do what we call rotate call. But what most parents don't realize is who is actually present in the room when you're giving birth matters a great deal. And even though I had all of these things stacking up against me, like it looked like I was heading for a C-section, everything that happened, the whole way of my birth. In the end, I did not have a C-section, and I'm not demeaning C-sections. They can be necessary, but this would not have been necessary if I'd had one. It would have been avoidable. And the reason I did not have one is my doctor believed in me. She said, I knew you could do it. I knew you wanted a vaginal birth. And so she was patient with me. She gave me more than 3 hours to push and never once mentioned the C-section word. Most doctors at that hospital would have given up on me after 1.5, 2 hours max, even though the guidelines suggest 4 hours is normal with an epidural if it's your first baby for pushing. So, but she was aware of the latest evidence, and we had a trusting relationship. And so that made kind of a big difference in the impact Because then, because I'd had what people would label as a low risk, kind of somewhat uneventful birth, even though it wasn't uneventful to me,
Right.
that gave me more options the second time.
Right.
Right. So the second time I did choose to have a home birth in large part because I knew I could, birth the baby. And my confidence was because my doctor had supported me in the birth that I wanted.
So let's go back to you being afraid to be a squeaky wheel because I feel like that is something that, especially the average mom, is going to deal with. Well, not even just squeaky wheel, it might just be completely uninformed. But then when you are informed, so we'll just say, like, all right, birth education and being informed, that's a major issue. Like, you just go and you assume, I would assume the average person doesn't go into a hospital and go, well, they're going to be making decisions based on convenience and finances and things like that. And I
Right.
am so, but once you become informed, and I'm just picturing like, I've chosen this OB. They've said everything the right way when I was interviewing them. And then, they bring up something like, I don't know, what's your favorite standard practice that sucks? Like early induction? Is that
So if you're talking about in labor or towards the end of pregnancy,
towards the end of pregnancy?
yeah, if at the end of the pregnancy, they could say, Rebecca, I know, you wanted to wait for labor to start on its own, but this baby's getting really big and you had a lot of trouble birthing a 6.5 pound baby. So I think it's better if we go ahead and induce right now at 39 weeks. Even though I know that's not what you wanted, I think it's safest for your baby and you don't want anything to happen to your baby, do you?
There's no way that, like, what do you say to that? And that is so we're in a very rural area, and in the last 14 years, I think when I first started practice, there was probably, like, 7 different birthing options within a 45-minute, including a birth center, and now there's 1, and you have to drive an hour to get to. And I've just seen the rate of induction go up. Like, I literally turned to my associate doc a couple months ago, and I'm like, "Am I crazy? Did we get worse at what we're doing at helping our patients have the birth they want? Or has the hospital gotten crazier about inducing just, like, left and right?" So that is legit happening, but how is a mom supposed to, in that moment, say, "Nah, I'm good"? Like, are you using research here?
So that's one of the reasons I started evidence-based birth. So if you Google like evidence-based birth big baby, you'll go to our signature article on this topic, which was a peer-reviewed article of all the research. And we also have a one-page handout you can download for free. And then the whole article with all the references is there. And I really believe information is power. So that's one key part of it is having the information. And ideally, you would know about this kind of pitfall or booby trap or whatever you call it
You'd be
before.
prepared before.
Yeah,
Yeah.
before it happens, because if it's said to you, that can really do a number on because what mom is going to say, well, I don't care what happens to my baby.
Right.
That's just not even on your radar. And so, one of the problems with the field of obstetrics is there's a lot of what some people call it mistreatment, some people call it obstetric violence, but coercion and manipulation is part of that.
'Cause, your baby's life is on the line. Like,
Right, right. When the research shows that, first of all, it's very difficult to predict which babies are going to be large. So, actually, about 1 in 3 American women are told that their baby is too big to birth vaginally. And yeah,
1 in 3.
1 in 3. So it's quite common to be told that. But ultrasounds are notoriously bad about predicting big babies. So it's right about half the time and it's wrong about half the time if it says you're going to have a big baby. So if you know that, that's one thing. And then also knowing what your preferences are for the birth, what you're feeling most comfortable with, not comfortable with. And I think in terms of like how I would respond if a doctor said that to me, if I had the information and I knew that, I would probably say, thanks for that information. And, I'm going to continue with my plans. I like using the thanks and instead of thanks, but. It's
Mhm.
just a simple communication technique. If you say "but" to someone, it always makes you look more confrontational, but if you're just
Mhm.
saying "and," it means I'm considering what you're saying and I'm making a choice otherwise. If I did not know the research in advance, I would probably use something called I would recommend using something called BRAND, which is an acronym that stands for benefits, risks, alternatives, nothing, and discuss and decide. So, what are the benefits of inducing
Mm.
at 39 weeks? What are the risks? What are the alternatives? What if I do nothing? And let me think about it. And most of the time with induction, unless it's something for like preeclampsia, it's not urgent. So you have time to think about it. And sometimes creating time and space is all you need to really center yourself and figure out and find out more information, get the facts, and then make a decision without feeling pressured. So I have also had friends who are recovering people pleasers. And when a doctor says something like that to them, they have to say yes. It's like a fawning response as well
Mhm.
to, kind of bow down to someone in a position of authority. So one thing I've had or seen people do before is say, okay, whenever when do you want to schedule it? And then they'll schedule it and then they just like won't show up or
They
they're call and
ghost it.
cancel. Yeah.
Seems like it's a
I
great
know.
yeah.
That is something I would reserve for somebody who really has trouble speaking their truth and needs another way out. And I'm not saying if you're listening, if your doctor says to have an induction, just ghost them. I'm just saying I've seen that happen before in people who are making an informed decision not to have an induction when they feel so much pressure, they don't know any other way to say no because no's are not always respected, you know. It's
Definitely not.
the whole concept of informed consent. And then you mentioned inductions. The other thing reason you're probably seeing the induction rate, especially since you're in the Wisconsin area, which is closer to Chicago, which was where the big Arrive randomized controlled trial happened. Are you familiar with that?
No.
Okay. So the Arrive trial, it's an acronym as well, was published in 2018 in JAMA, the Journal of the American Medical Association. It was a very large randomized controlled trial on electively inducing labor at 39 weeks
Okay.
versus waiting until labor starts or you need an induction, which is called expectant management.
Okay.
So in this study, which was the lead investigator was in Chicago, and it was done at I think around 40 centers around the country. And their goal was to show that elective induction at 39 weeks is good. So the doctors in charge of the study believe that nothing good happens after 39 weeks and everybody should be induced a week before their due date.
Okay, but hold up, hold up. Okay.
Yeah.
So this is 2018 and
Yeah.
they want to prove this. Now, up until this point, is there research that goes against them? There has to
So
be,
there
right?
was mixed research. There hadn't been like a large randomized controlled trial. There had been smaller trials, there had been observational studies. So they kind of wanted to come out with a definitive answer to the
Yep.
question because the obstetric community was somewhat split at the time. A lot of OBs believed that you should induce by the due date, preferably a week before the due date, whereas other OBs were like, well, you can wait till 41 weeks to induce like a week after the due date. So and there's pretty strong evidence saying that 41 weeks induction is more beneficial than waiting to 42 weeks.
Oh,
But
okay.
the doctors were wanting to move it back to 39. And part of their theory was, well, we'll have fewer stillbirths if we induce everyone at 39 weeks. And so they also thought it would lower the C-section rates. They were looking at this. The first primary outcome was a combined outcome of stillbirth, newborn death, major newborn complications. That was
Right.
a combined outcome. That was their number one thing they were trying to prove. And the second one was the C-section rate. So
Which
what ended up
again, I'd like to
happening?
point out is, like, it seems good. Like, it seems like there's good intentions, like, it's
Yeah,
not
yeah.
like I know a lot of times people who go down this rabbit hole birth of, like, it's all about money and convenience to the doctors, and I do believe that, like, yeah, a hospital has to stay open in order to provide services, but, like, I do believe that, like, the root is, like, trying to keep mom and babies alive.
Right, right. There is that intention behind it. It's also philosophy. So you've, two very differing philosophies. There's the medical model of care, which believes that, birth is inherently dangerous, women's bodies are inherently risky for babies. And then you have the midwifery model of care that's more about informed choice, autonomy, acting more as a lifeguard where you trust the process, but you're there to jump in if something goes wrong. So
Right.
those are the two very different models. So this is coming from the medical model.
Yeah. Okay. So
And
anyway, so back to the Arrive
yeah,
study.
so anyways,
Sorry.
what they found was they found no difference in the overall newborn outcomes. Okay. But they did find that the C-section rate was 19% in the induction group and 22% in the expectant management group. And that was statistically different. And they said, all right, that's good enough for us. And doctors all around the country started saying, you need to induce at 39 weeks to lower your risk of C-section.
Hmm.
And so that's one reason you might be seeing this. There doesn't have to be a medical reason. This is a completely non-medically indicated
Mm-hmm.
induction.
It's just,
And they're just scheduling them for everyone and acting as if it's standard. Some women are told, you don't want your baby to die, do you? So they're still getting that same spiel, even though the research did not support that line of thinking. It did show a lower C-section rate. There's some questions as to why. I think have you ever heard of the Hawthorne effect?
no.
It's a known problem with research studies where doctors and nurses behave differently when they're being watched.
Oh.
So if you want something to be better for one group, maybe they worked extra hard to prevent C-sections with the induction group. And I've seen that if you want to induce someone and you really want to avoid a C-section, it is possible most of the time. You just have to be really patient. You have to expect the process to take up to 3 to 4 days and nights and be prepared to support them through that. And the parents have to be prepared for that too.
Well, I would just
So,
like to point out that that 2018 study sure, got integrated fast. There's no
yes, even
15 to
though
20
okay.
year, like, delay on that one. They're like, "Cool, let's start this next week."
So what I have seen is that the things that get integrated fast are things that prove something that OBs already want to do and things that increase restrictions on parents. So, for example, during COVID, one of the things that happened really fast was kicking doulas out of hospitals because they thought it was dangerous for disease control and management or infection prevention. And then it took years in some cases for doulas to be allowed back in, even though there was no evidence showing that they were harming anyone by being in the room. In fact, a lot of health outcomes got worse while doulas were not allowed to be there. So that's the deal with the Arrive study. It had a really big impact. You can learn more at our website, evidencebasedbirth.com/arrive. We have a one-page handout on that as well. And that is, again, another kind of roadblock or something you're going to stumble into in pregnancy if you're not aware of it. Of course, again, going back to the different models of care, the medical model of care, I would say it's more typical than not that an OB will offer an elective induction at 39 weeks or recommend it or push it, whereas midwives almost never do because the American College of Nurse Midwives came out and they said, although this study came out, showed a slightly lower C-section rate, we believe that patients should have the choice and we believe in physiological birth and things go smoother when you're not trying to intervene. So again,
Mhm.
there's these philosophical differences. And I would say you don't need, if you're trying to lower your risk of C-section, there's a lot better ways to do it than an induction. So hiring a doula would be number one. That'd be way more powerful than going to be induced. On the other hand, the Arrive study showed if you want to be electively induced, let's say you're just sick of being pregnant, or maybe you have a partner that needs to leave town, or you've got severe, discomfort in your back or pubic bone or whatever. And I would say that's a medical reason. But having an elective induction at 39 weeks is also not a terrible thing.
Mhm.
It's a decent choice for somebody who wants it. The
Mhm.
problem I always have is when people are pushed into it. That's
Right.
not okay with me.
Okay, so we've talked about big baby myths. We
Mhm.
talked about the 39-week induction thing.
Mhm.
I think that I don't really think that there needs to be much discussion here on like birth, mom chest to chest. Like I feel like
Right.
that's pretty been well integrated. I mean, your story
Yeah.
not so much, but like what about the broken water, the water break, 24-hour, the clock is ticking situation.
Mhm.
What's research say around that?
So it's kind of similar to a lot of the other things. The research is mixed, and there's benefits and risks to both waiting and inducing. I think again, you'll see when you look at the medical recommendations, the doctor groups tend to lean more towards inducing right away, whereas the midwifery groups tend to lean towards giving it at least 24 to 48 hours. And we do have a full peer-reviewed article on that as well. It's called premature rupture of membranes. We call it PROM in the birth world, which always makes
Got a
people
lot of
think of a
acronyms.
dance. I
Yeah.
know. So, evidencebasedbirth.com/PROM. Again, chiropractors can download the free one-page handout to use with your clients. And then the full article is there underneath it as well. And so that's, again, a complicated subject. For me, I experienced PROM in my first birth. And this is another thing that can derail your birth plan, right?
Mhm.
Especially, I think a lot of chiropractors probably care for people who want a more holistic physiological birth. And so it can be really discouraging when something like PROM happens, because then again, you're talking about induction. And induction is a major medical intervention that involves having a whole bunch of medical interventions. So if you weren't planning on having interventions, it can be really demoralizing to experience PROM. But the research does show that in most cases, if you meet certain criteria, it's okay to wait. And I don't have all the criteria memorized off the top of my head there in the article. But, if you don't have a fever, if the amniotic fluid is clear, if baby's moving well, if you want to wait, and also if nobody has done a cervical exam on you, because as soon as you do a cervical exam, you're increasing the risk of infection. And the more exams you have, there's like a dose response increase in the risk of infection. Because once the waters have broken, there is a portal, if you will, for like bacteria to get through. And how they typically get through is the hand going up, pushing the bacteria. Even if the doctor's wearing sterile gloves, they're still pushing the bacteria from the outside to the inside.
Right.
So you can use a speculum exam instead, and that is less risky. But the 24-hour clock thing has been debunked. You don't need to be put on a clock in terms of the baby must be born by 24 hours.
Mhm.
But they'll start watching you for signs of infection more closely. So, because
I
that
feel
is a
like as we're
possibility.
talking, I have all these, I'm like, "All right, so what about the 42-week your placenta is dying thing? What's the research say on that?"
I haven't seen much research on placentas like dying at 42 weeks or not functioning as well, although that is something that doctors will say. We do know that, stillbirth rates start to go up after 39 weeks, and they take a sharp turn upwards at 42 weeks. So, what that's due to, we don't really know. But I cover the evidence on
We
that.
don't know.
They don't know why, but there are theories, but nobody knows why. I mean, it's something that's really hard to study, you know?
Is it hard to study because a
It's sort of
woman
rare,
just
you
had it?
know?
Yeah.
Yeah, and it's hard to enroll people in a study right after they experience something
Mm.
like that. And you're not nobody's inside the uterus monitoring everything that's happening up until an event like that.
Mhm.
So it's not always clear. In fact, a large percentage of stillbirths, more than 50%, never have a known cause.
Mhm.
So there are groups out there that are advocating for more research to be done for stillbirth families on both prevention and like causes, that sort of thing.
I don't know if there what the question is in
Mhm.
this, but, like, so when, you said you listened to Nathan Riley's,
Oh no,
episode?
I did. I listened
Okay,
to.
but you know who he is?
Mhm.
Okay. So he kind of brought up just briefly when we were talking, it was like this, how just afraid we are of basically the baby dying. And that's why, and like in my head, I'm like, well, of course. And so what's hard is like, I'm hearing like, okay, we need to have more informed women. But like, I'm picturing, looking at a piece of research and it's saying like at 42 weeks, there's a, 17% increase in stillbirth. And I don't know how, like, How if we're doing all these things, that's like, okay, it's reducing this study says this reduces the stillbirth, this reduces this. Like, why are we still so bad at it? Like, why aren't we getting better in the rankings?
So it's a good question. I'm looking up quickly. I was just talking with a reporter about stillbirth, and like I said, it's underfunded. So it's not an area of research that gets a lot of money put into it, sadly. And there are groups, however, that are working on this. I think one of the organizations that I really recommend is called Count the Kicks. Have you ever heard of
Mm-mm.
them? So you can go to counttthekicks.org, and they have a compilation of a lot of research on stillbirth prevention. And they have published and referenced studies where they find that implementing educating simple education to parents about how to kick count and using a specific app to do it, which is free, can lower stillbirth rates by 30%. So there are people and groups out there, and the World Health Organization has an info page about preventing stillbirth, which I can send to you for your show notes. And I'll send you a few other articles. But I think it's a huge problem worldwide. And in terms of the specific rates and the risk, there's a difference between relative risk and absolute risk. And a lot of clients won't know that. So when you say the risk goes up, so let's say by 50%, what does that sound like to you if you were a layperson and didn't know what I was
Sounds
talking
like my baby's got a 50% chance of living.
about? Right. But what if I told you the baseline risk
Mm,
was like, I'm just making up a number, 0.2 out of 1,000.
right.
So a 50% increase of that would make it
Zero point
0,
0.3.
0.3 per 1,000.
Yep.
Yeah. So I am a big believer in educating parents about the difference between relative risk and absolute risk, and then making sure they can find the absolute risk numbers, which are not always easy to find, but we do at our website have an article on due dates. So it's evidencebasedbirth.com/due dates, and it has all the numbers in there.
Okay, so you wrote a book, Birth is Not I don't have it in front of me. Birth is Not a Pizza, right?
Babies are not
Yeah,
pizzas.
there we go.
They're born, not delivered.
Yeah.
Yeah.
So as we talk, I'm hearing some like I'm assuming that, picking your providers wisely or
Mhm.
your providers and where you're gonna birth,
Right.
becoming informed.
Mhm.
What else helps fix this?
I think so. The top thing is finding your provider in a supportive birth setting, because if you have that, you might not even need some of this information because they'll give it to you,
Mhm.
right? So,
What a
but
concept.
yeah, but the problem is a lot of people will say, I don't have that. Maybe I do live in a rural area,
Yeah.
maternal care desert, or I live in a city where the culture is really bad. There's a lot of obstetric violence. So if you don't have that, then usually what I talk about is getting educated yourself, you and your partner, because you can't carry the burden of all of the knowledge. Once you're in labor, you might not be able to speak up for yourself. So you need a partner who's just as educated as you. Get labor support, preferably from a doula, and build your communication skills. That's something a lot of people don't think about, but especially if you're a people pleaser, which a lot of women are, working on using your voice and speaking up for yourself is really important. And we practice that we have childbirth classes at EBB where we will literally rehearse a
Really?
conversation with a nurse or a doctor, and I'll pretend to be the doctor and I'll ask you a question, and you have to respond, or we'll rehearse the partner introducing themselves and shaking
Hospitals
the
have to
hand.
hate you.
Huh?
Hospitals have to hate you.
I don't think they hate me. We
They're
have a
like, "Did you go to Dr. Rebecca's class?
I
You're
know.
branding me. I can hear it right now."
I know, right? No, we actually have a ton of labor and delivery nurses that listen to our podcast. So in the beginning, maybe the hospitals hated me, but I think they found in some ways although it might slow down their ways of doing things a little bit, at least they don't know if they don't like me, they probably don't know who I am. So that's a good thing. So building your communication skills. So we actually will have the partner introduce themselves to the doctor and the nurse and shake hands and say thank you so much for caring for us today. So it's all about like building the communication
Mm.
skills of the partner, even more so than the person who's giving birth. And then knowing what your human rights are. So knowing that you have the right to bodily autonomy, knowing the right you have the right to your bodily functions. So nobody can tell you to eat or not eat, move or not move, those kinds of things. And then the final strategy we teach in our childbirth class is to humanize the room. Because a lot of what's happening is people almost go in this like automated robot mode where they're just doing their job and they just want to get their job done. So getting them to see you as a person and then you seeing them as a person, it levels the playing field and just getting everybody on the same team.
How do
So
you humanize the room?
in a hospital
Yeah.
setting, there's lots of little things. Doulas are really good at this too. I mean, just something as simple as putting twinkly lights in the room and calming music, bringing treats that you offer to the nurses, and then using names. So, like, saying, Lauren, it's so nice to meet you. We're so glad that you're our nurse today. And hey, Lauren, do you think we could have this? And like using names and referring to your partner by their name, trying to engage them in conversation about, what team do you root for? Just getting to know people on a human level instead of it being just all business is really useful, because if you think about it from the hospital staff's perspective, they have a very stressful job. They interact with a lot of people who don't appreciate them and don't care for them.
Mhm.
And the last thing you want to do is come in there and just like steamroll them and be rude. So it's all about
Hearing
treating
you
them like a
talk,
human.
this is how I treat, the check-in person at the hotel because
Exactly.
I really want an upgrade. And so "Hey, Tony, how are you today?"
Yeah,
Uh,
not in a fake way,
but in this way,
but
you really want a nice birth outcome, so suck up to the nurses.
yeah, well, and I
Does this
hate to say
make
it's
you
like
sad?
you could look at it that way. I mean, you could look at it as a manipulation, but you can also look at it as like, I just want to connect with these people because they're going to be here at a very important moment in our life.
Mhm.
Right? And
Yeah.
so building that relationship can be really special, because if the nurse is on your side, it can make all the difference in the world.
Right.
And so the other thing, one reason I think it's important to humanize the room is not just for yourself, but for the healthcare staff. Because at any point, 1 in 3 nurses or doctors who walks into your room is suffering PTSD from a previous birth,
Oh,
from
whoa.
witnessing things. So it's all about having compassion for them and for yourself.
Yeah.
And it's like, if you can do that, that's why I say, if you don't have the supportive provider, the supportive setting, that's why you get educated, you get labor support, you know what your human rights are, and you go in there not necessarily fighting, but wanting to connect with them.
Mhm. Yeah, more of a team mindset.
Yeah, team mindset. Mhm.
I love that. Gosh, it's such a big problem that,
Mhm.
wait, I don't think we solved it in this hour, Rebecca. I
No, I
think you're
don't
doing a
think we
really good
could.
job. I think you're doing your part though. Okay, where can people find your podcast, your book, more I like your website? It sounds like you have tons of resources there.
Yeah, and we love chiropractors. So, please check out our work, because if you're planning on having a baby, it could help you. But more importantly, I think with your clients, having resources you can give them that you find trustworthy is important. So, to listen to our podcast, just search for Evidence Based Birth on your favorite podcast platform. We have a crash course on what we believe the definition of evidence based care is at our homepage on our website. So, evidencebasedbirth.com. You can just Google evidence based and it usually starts to autofill. And then we're on Instagram at EBBirth. And we have a YouTube channel. All of our podcasts also go on YouTube at Evidence Based Birth. And then you mentioned my book, Babies Are Not Pizzas. That's a really great way to start to kind of learn more. And we have a childbirth class on our website that is taught by instructors all around the world. So you would just refer them to that website and they can find an instructor either near them or online.
Do you do certification for people to become an instructor?
Yes, and chiropractors are eligible.
Oh, good.
So, yes, so
That would
if
have
a
been an awkward, like,
chiropractor
they are, but you're not counted.
Yeah, yeah. So chiropractors are eligible, as are acupuncturists, doulas, childbirth educators, nurses, midwives, and doctors. So you can go to evidencebasebirth.com/instructor, and there's a wait list. So we open up that program every summer. It's by application only. We judge the applications. We accept the most qualified people. And then you can go on and teach our childbirth education classes and also teach workshops for labor and delivery nurses about comfort measures in labor
Mhm.
and other workshops for parents. So,
I love that. Thank you
yeah.
so much. I really
Yeah.
appreciate your time. And we'll have, whatever links you send my way, we'll have that in the show notes. And yeah, I just really appreciate it.
Yeah. Thanks, Dr. Brunslick.
All right, She Slayers, until next week. Bye.